Hello, everyone. Welcome back to Neurospicy Nursing. This lecture is kind of a segue of taking those ABGs that we learned about in the last lecture video and how to apply them to certain conditions. In this case, it's going to be DKA, and we're going to do a background overview of type 1 diabetes as well. So, just so that you guys know, this is to take the ABG interpretation and put together with the DKA management to help create a baseline, help recognize patterns, and then how we would apply it to a real crisis. So this is the normal ABG values. pH, anything below 7.35 is going to be acidic. Anything above 7.45 is alkaline. For the PaCO2, anything above 45 is acidic. Anything below 35 is alkaline. For me personally, I like to remember these flipped just so that when I draw it like on my little whiteboard, it makes sense that all of the acidic things are in the same column, and then all the alkaline things are the same column. So remember, PaCO2 is flipped. And then our bicarbonate, anything below 22, that is acidic. Anything above 26 is going to be alkaline. Those three are going to be most important for when we're talking about ABGs. All right, and then again, just remember when we're talking about respiratory, PaCO2 is opposite. So when you have a high pH, your PaCO2 is going to be low. So when you're more alkaline, your PaCO2 is low. When your pH is low, PaCO2 is up. And then our metabolic, so our pH is equal to, so they don't raise at exactly the same rate, but if you see an increase in one, like pH and bicarb, it's going to indicate some sort of metabolic alkalosis or acidosis. Okay. So, respiratory acidosis. So, again, this is anything with a pH that's below 7.35 and a PaCO2 of greater than 45. A super common cause of this is hypoventilation, like if someone's having anxiety or some sort of anxiety attack. That, um, sorry, backwards. I said hypoventilation. So this would be if someone had like COPD, their lungs are obstructed. That would be a low amount of like oxygen, CO2 in their body. And that causes the buildup of that carbonic acid. And so that's when we see that respiratory acidosis. So again, we see this in pneumonia, COPD. We can also see it if someone's having an opiate overdose. Also, we will see it because at this point, our kidneys are trying to compensate, and then they're going to compensate by retaining their bicarbonate. Some other things that we're going to see, obviously slow breathing, that's a good pointer to the opiates. You also may see confusion, some lethargy, they might have a headache. When we have respiratory acidosis, it's very common for us to get hyperkalemia, so high potassium. If you guys have not watched my lecture on the electrolytes, make sure you guys do that. And then these individuals will have an increase in vasodilation, so that will cause warm and flushed skin. Okay, respiratory alkalosis. This is where I switched it up last time. Hyperventilation. So if someone is having a panic attack, this is when you would see alkalosis. They're breathing too much. So they aren't being able to eliminate enough carbon dioxide. Or they're eliminating it more than it's being produced, actually. Okay, so kidneys, they are going to excrete more bicarb. Again, causes anxiety, panic attacks, pain. Sepsis is also a really, really good thing to look out for. And then you also could get a PE. These individuals, they have they're breathing very rapidly because of that chest pain. So it might be indicative of a pulmonary embolism. So again, they'll have tachypnea, they'll be lightheaded because of that hyperventilation. They'll have tingling in their extremities because their calcium levels are going to drop. And then because their calcium levels are dropping, there's a potential for some cardiac arrhythmias to happen. Okay, metabolic alkalosis. So this is more alkaline, more basic. So this is too much bicarbonate in the body. What's happening here is that your body's going to start hypoventilating to help retain CO2 to compensate. And that is going to obviously be all based on how much oxygen you're taking in, right? So another reason that we see metabolic alkalosis is from people who have NG tube suctioning for a really, really long time, or if they've been vomiting. Other things that we might see are from diuretics, like diuretics that are wasting of potassium, like your loop diuretics or your thiazide diuretics. A loop diuretic is like Lasix. Also, if they take a lot of antacids, like let's say they have, I don't know, peptic ulcer disease, that might also be a reason why they have alkalosis. And then there's going to be other clinical cues that you can see. Obviously, that shallow breathing, that low potassium, you'll see that. Because of the low potassium, they'll have arrhythmias and then they'll also have muscle cramping. For metabolic acidosis, this is a pH less than 7.35, a bicarbonate of less than 22. These individuals have a high anion gap, so it's going to commonly be seen in individuals who have renal failure, they've been exposed to certain toxins, and DKA, which is what the primary purpose of this lecture is. And then you're going to see something called Kussmaul breathing. It's a very deep and rapid breathing pattern. Okay, so here's just a little bit of a chart for you guys to help kind of put things together, what they look like for respiratory alkalosis, acidosis, metabolic acidosis, and alkalosis, and what these levels are going to kind of look like. And then their primary problems and a classic scenario example of each one of those. All right, so getting into DKA. So one of the big things behind DKA is that this individual's blood sugar is going to be very high. Also, make sure that you know that DKA is going to happen in individuals with type 1 diabetes. So what's happening here is that glucose is not able to enter the cells, right? Something's blocking it off. It's like a little gate, it's blocking it off. So because it can't enter the cells, what's happening then is it's causing the blood glucose levels to skyrocket. Because of that, it causes glucose to spill into our urine, and it's going to pull other electrolytes into it. It's going to pull also our ketones and stuff like that. These are the glycoproteins, and that's going to cause something called osmotic diuresis and the ketone bodies. So when you do your urine dipstick test, you'll see that they have glucose in their urine, and you'll see that they have a presence of ketones. So because of those things, what you're also going to see is these individuals are going to be very, very dehydrated, and then they'll also have metabolic acidosis. So when looking at kind of the standard stereotypical signs for DKA, We have the Kussmaul breathings, like I mentioned before. They also will have a fruity breath. That's because of the buildup of acetone in the body. They're obviously going to have signs of dehydration. Obvious signs of dehydration are hypotension, tachycardia. They'll have nausea, vomiting, and abdominal pain. And some individuals will have altered mental status if it has progressed pretty severely, anywhere from being drowsy/lethargic to coma. If you haven't watched my video on the Glasgow Coma Scale, highly recommend you watch that. It explains a lot about altered mental status, kind of how we rate that. We would also be using that same scale to rate these individuals. Okay, then looking at their labs, blood glucose, it's going to be greater than 250 milligrams per deciliter. Some textbooks will say greater than 300 and others say greater than 330. Go based on whatever your hospital policy is or whatever your textbook is saying for the purpose of your tests. Ketones, again, I talked about doing that deep dipstick test. They will be positive for ketones because, again, that protein is spilling off into the urine. Then our pH is going to be less than 3. So remember, it's or 7.3. So it is acidosis, so it's less than. Same thing with the bicarbonate. Remember, if it's less than for bicarb, it's also less than for pH. And our anion gap is elevated. That just means that there's a specific amount of unmeasured ketones. Okay, so again, we know it's DKA because we can see that there's a low pH level and a low bicarbonate level. Make sure that you guys know kind of like the ranges of your ABGs, at least semi know them. NCLEX will give you those levels because, in EPIC or other EHRs, EMRs, those levels are there. They'll pop up in red whether they're abnormal or not, but it's still a good thing to know. And then in this case, their PaCO2, it's still within a normal range. It has lowered itself, but it's still within normal range. So we know that it's going to be, because the other two numbers are more out of range, that it's going to be metabolic acidosis. Okay, so there is also a management protocol for DKA that is very similar to one that you guys have heard before, the ABCs. It's still airway and breathing for A and B. C is still circulation. Those are always going to be top priorities for our patients. Airway, breathing, circulation. B in this case is not going to be disability. It is going to be dehydration and deficit correction, because you have to make sure that you are fixing that dehydration. So we'll usually start with a bolus. You want to start with an isotonic solution because it can restore balance a little less aggressively. And then once you semi-restore that balance, and that's when you'll switch to your half normal saline, so that 0.45, to make it even more hemodynamically stable. But always make sure that you start with the normal saline first, especially for a bolus, because you don't want to overcorrect it too quickly and now they have too much fluid. The other thing that we're going to do is, because these individuals are going to be on an insulin drip, we are going to make sure that we prevent their blood sugar from going too low. So it's normal to see D5 or dextrose added to fluids just once that blood sugar has started getting below 250. Now, someone may present with, a blood glucose of 320 when you first get there, and then an hour later it has now skyrocketed 400. So you have to make sure that you're monitoring those blood sugars because they can go up. The other thing that I mentioned D is going to stand for is that deficit correction. So again, there'll be a regular insulin drip. It's usually based on their weight, the amount of units that they'll get per hour. So what it does is it helps the glucose shift into the cells, but by doing that, it's also going to drive potassium into the cells. So that is going to cause a risk for hypokalemia, so too little potassium. So we have to make sure that this person is on cardiac monitoring, that you're also monitoring for any arrhythmias, and that's where E comes in for the electrolyte correction. You'll also see potassium given to these individuals on a drip as well, if they're not awake, still comatose, and if they are awake, a little bit more awake, they might start getting pills. Don't forget, don't ever push potassium IV. Needs to be a very, very slow drip to kind of prevent it from burning if you can't give it with a piggyback lidocaine. And then if they are taking it orally, this is not it's a huge pill, but unfortunately you shouldn't be like chewing it or breaking it in half. It's one of those things that is specially coated so that it breaks down in a certain amount of time. Okay, and then other things that we're going to do for DKA patients is obviously we're going to monitor their neurostatus, monitor their vital signs, and that heart arrhythmia. You're going to need strict intake and output for these patients. So obviously, however much fluids you're putting in, you also need to make sure that they're not overspilling, pushing too much fluid out, sign of dehydration, right? You're also going to check hourly those blood glucose levels and those potassium levels because you don't want them to go too low or raise up too high. In the case of the blood glucose, like again, raise up too high. And then you're also going to watch for cerebral edema. A really good indication of this too is that altered level of consciousness. They have a headache. Also, this could be from correcting those fluids too quickly. We're also going to make sure that we now meet the criteria. Again, every hospital is different, so go based on your hospital policy, but their blood glucose level should at least now be below 200 milligrams per deciliter, and their bicarbonate and pH levels have hopefully stabilized, as well as their anion gap. And then we have to make sure that we're figuring out what is it that caused this to happen? How do we prevent it from happening again? Are they doing their sick day rules? These are going to be very important for our diabetic patients. We will make sure that we go over them in the next video, all about sick day rules, what they are, how they work, and how they prevent DKA. And that's all I have for you guys then. Thank you. See you in the next one. Bye bye.